Well, welcome back, everyone. In the last sequence, we talked about the role of randomization and how it enhances comparability, how it tends to balance the two groups you're comparing with respect to potential confounding factors, factors that could influence your outcome. Randomization, either through simple randomization in large studies or blocked randomization in small studies, might guarantee that equal numbers of old people will receive one treatment, say treatment A versus another treatment, treatment B, new treatment versus standard of care. So randomization works well to set the stage for your experimental study, to give you a starting point of having two groups that are comparable with respect to other factors that could influence your outcome. They minimize something called confounding, something we'll be talking about a lot in future lectures. But now what I'd like to talk about is what happens after randomization, the post-randomization problems. Let's suppose you have a large randomized trial and you did simple randomization. Or let's suppose you have a small randomized trial and use blocked randomization after stratifying by age, for example. You have two groups that look like one another. They have the same age distribution. Whatever outcomes occur among one group, if they're different from the other group, you can't blame it on one group being older or younger than the other group. So randomization gives you a good starting point. But now let's talk about post-randomization problems. And what I mean by post-randomization problems, ideally, what I want to happen in an experimental study is I assign people at random to receive, say, new treatment or standard of care. I want to follow those people over time and see what happens to them. Ideally, I want everybody who I assign to the new treatment to take the new treatment. Ideally, I want everybody who is assigned to the standard of care to take the standard of care, because I want to compare people who actually received the new treatment versus people who did not. And what I have are two groups that were assigned to receive the new treatment or assigned to receive the standard of care. And the problem is, will people accept their assignment? Will they comply with their assignment? You're told to take this particular pill every day. Some people might choose to take it. Some people might choose not to take it. That's what I mean by compliance. So poor compliance with assigned treatment is one potential problem in a study. Post-randomization that I'd like to minimize. Another potential problem, which is a sort of compliance problem, is withdrawal from the study. When I enroll people in the study, I have to get their consent. Their consent is, I agree to enroll in this study. I explain to them the benefits and the harms of the two treatments I'm comparing. People can choose on their own to leave the study anytime they want. I can't compel people to be in the study. That's unethical. So there might be people who withdraw from the study. And what I might really be concerned about is if these people who are withdrawing more likely from one arm than another. Maybe I'm having more withdrawals from treatment A than from treatment B. That might upset me, but what would really upset me is that the people who are withdrawing from treatment A are the people who are likely or unlikely to develop the outcome. So if the reason for withdrawal had any relationship to both the treatment that was assigned and the outcome, I have a potential selection bias when I eliminate those people from my study because they withdrew from my study. I might be eliminating in the treatment arm the highest risk people for developing a bad outcome. And the people who are left over might have lower outcomes, better outcomes from the people who were assigned to the standard of care. I might erroneously conclude that this new treatment is better. Well, it's only better because I only analyzed the people who didn't withdraw. And those were the people who had the better outcomes. The people who withdrew might be the sickest people who withdrew. So withdrawal after randomization is a problem. The other problem that could happen after randomization is if I'm the investigator and I'm measuring outcomes on those people who are in my study, if I knew which group they were assigned to, that information might influence how I record those outcomes. It could happen on the patient level also. If the patient knew which group they were in and the outcomes were self-reported, like how do you feel today? I have less pain. Do you feel you have more energy? The answers a patient gives might be influenced by the knowledge that they are either receiving standard of care or the new treatment, and we don't want that influence to happen in a study. So all these are potential problems that could happen after randomization. Now, how can we minimize at least the potential for some of these problems? And there are a couple of ways of doing it. One way is something called blinding. Blinding means don't tell people what treatment group they're in. If I don't know whether I'm in treatment group A or treatment group B, I'm asked to take a pill. I don't know whether that pill is a new treatment for my condition or the standard of care treatment for my condition. I don't know which treatment I'm giving. That knowledge cannot influence me, the participant, from how I react in that study. It cannot influence whether I choose to comply or not to comply. It cannot influence whether I withdraw or not withdraw from the study. It can't influence how I answer your questions when you say, how much pain do you have? Or how much energy do you have? Or how do you feel today? Excellent, very good, good, fair, poor, to go back to an example we used earlier in this class. If that knowledge of what a treatment I received is also blinded to my primary care physician, even though I'm in your study, I'm still seeing my physician with other health problems I might have. If my physician knows I'm getting the standard of care or knows I'm getting this new treatment, not getting the standard of care, they might treat me differently with respect to other conditions that I might have, comorbid conditions. That other treatment that this physician gives to me might influence my outcome, how much pain I have, how much energy I have, how do I feel, and things like that. So I want to blind the physician also, who's caring for the patients, from what type of treatment a patient is giving. And finally, I want to blind the investigator themselves, because if the investigator is the one collecting the outcome information, interviewing the patients, the patient might be blinded. He doesn't know what treatment they're giving. He's just taking a pill every day. But if I, the investigator, knows that this patient's receiving the new treatment, and I ask, how much pain do you have? And the patient responds, it's hard to say. I might interpret that differently, record it differently, if I knew that person was receiving the new treatment versus the standard of care. All those are potential biases that could happen after randomization. All those might be minimized by this notion of blinding, or sometimes called masking, not letting the key individuals in the study know what treatment assignment is given to a patient, blinding the patient, blinding the investigator, or even blinding the physician who's caring for the patient. And that's why you sometimes hear phrases like double-blinded study or triple-blinded study. It determines how many different key members in this study are being blinded to the treatment assignment to minimize the potentials of poor compliance or withdrawals or bias reporting of outcomes in these types of studies. Now, how can you blind a person from the type of treatment they're giving? If I'm talking about patients who are either going to be treated surgically or, say, treated with radiation if they've been diagnosed with a cancer, there's no way I can blind that patient to the type of treatment they received. If they received surgery, they're going to know it. If they didn't receive surgery, they're going to know it. So there's some treatments that cannot be blinded to the patient. But if it's a medication, a pill, that could be blinded. If you could give a person two pills that essentially look the same, taste the same, smell the same. And so the patient doesn't know the pill they're taking every day is treatment A or whether it's treatment B. Now, I mentioned the role of a placebo in randomized controlled trials when you're not comparing treatment A versus treatment B, but you're comparing a new preventive treatment, like taking an aspirin every day or every other day to prevent the occurrence of heart disease. Let's suppose I want to do a randomized controlled trial, not in a clinical setting, but in a general population to see if healthy people given aspirins have better outcomes than healthy people not given aspirins. Okay? What I need is a way to blind the people to know whether they're taking an aspirin or not. So if one group receives an aspirin and one group receives nothing to do, then they're going to know, based on whether they're taking a pill or not taking a pill, whether they're in the aspirin group or the non-aspirin group. So how can you blind such people? By giving them a choice or assigning them to a group. One group's getting active aspirin in a tablet or a pill. The other group is getting a pill that looks like, smells like, tastes like aspirin. That's what we mean by a placebo, a pharmacologically inactive substance. It's a pill that has no benefit in it. It might look like the active aspirin pill. So the individuals taking these pills don't know whether they're taking aspirin or not aspirin. The whole goal is to blind people taking these pills to know whether they're taking the active drug, the aspirin, or the placebo pill. Now, this is only ethical if you're doing preventive trials. We cannot do a clinical trial of a new treatment by randomizing people to receive a new treatment versus nothing, because that's what a placebo is. It's nothing. In a clinical trial, we have to always compare a new treatment versus the existent standard of care. So placebos are usually limited to randomized controlled trials in non-clinical situations looking at the effect of a preventive agent, say aspirin preventing heart disease. Now, the reason we do this, the reason we want to blind, is the potential problems I mentioned by having the patients know that they're taking one drug versus another drug. That's sometimes labeled as the placebo effect. It's the effect due to the knowledge that you are taking essentially a pill, you're in a study. There's a classic study that was done, not in medicine, but in business, that led to a description of this problem known as the Hawthorne effect. It was essentially done by some investigators, not from the Harvard Medical School or the Harvard School of Public Health, but by the Harvard Business School. They were asked to develop an intervention to improve productivity in a plant, a power plant. The Hawthorne Power Plant, I believe, was called in Cicero, Illinois. And basically what they did is they developed an intervention, went to this plant, and essentially randomized people to receive this intervention or not to receive this intervention. At the end of the day, the intervention seemed to improve productivity. But then the investigators said, let's do something else. Let's try another intervention and compare people who received this alternative intervention versus nothing at all, and see if that other intervention matters. And it did. They found that either piping loud music or not piping music or soft music into the plant or raising the intensity of the lights or not raising them all seem to have an effect. The Hawthorne effect describes this subjective effect that people will show if they know they're in a study and they know they're being followed, they're going to act differently. They know that someone upstairs is caring about them because they're watching them carefully. And hopefully they're trying to develop an intervention that's going to improve not only productivity, but maybe worker satisfaction. So placebo effect refers to the subjective effect that patients will have just from knowing they're in a study, that their outcomes will improve, not because the intervention itself might be important, but because they know they were exposed to an intervention, they're acting differently. And they're acting differently in such a way that their outcomes are going to be different. So what is the whole role of a placebo? Is to have both groups, the people who receive the active agent, say aspirin, and the people who don't receive the active agent, both groups to benefit from this subjective knowledge, to know they're in a study, know they're being followed, know they're being monitored. So that could balance off that placebo effect in both groups, that subjective effect. Now, why is that important? I think a classic example that drives that home was a study that was published a number of years ago, known in 1980, known as the Coronary Drug Project. And I've given you the reference on the bottom here. There was a clinical trial after patients who had suffered myocardial infarctions, trying to prevent them from dying. Post-MI cardiovascular death was the outcome of interest. They had patients who were diagnosed who developed myocardial infarctions. Some of them were assigned to receive a drug known as clofibrillate, and others received a placebo. And at the end of the day, the investigators reported that the mortality rates from cardiovascular deaths were almost identical in the two groups. The active drug, clofibrillate, didn't seem to have any benefit. It wasn't any better. It was only slightly lower mortality rate, not statistically significant than the placebo group. But then the investigators dug deeply and they realized that not everybody who was assigned to this drug actually complied and took the drug. So they did a subset analysis. They just looked at the people who were assigned to the clofibrillate group and compared those who complied and took their pills versus those who didn't and didn't comply and took their pills. And they saw striking differences in their outcomes. The mortality rate among the compliers is much lower than the mortality rate among the non-compliers. And suddenly now it looks like, well, the reason we didn't see any difference in the previous slide is that people were not taking their assigned pill. They weren't taking clofazimine. And if you limit your analysis to just the clofazimine group and compare the compliers, people who took the drug, versus those who didn't take the drug, you see a benefit. The drug seems to work. The problem is they also did an analysis just looking at the people who were taking the placebo. Now remember, the placebo has no biologic effect on this outcome. It's just a pill with no active ingredients in it that should prevent your chances of dying. In the placebo group, they asked the individuals, did you take the pills that were assigned to you or not take the pills that were assigned to you? Some were compliers, some were not compliers. These individuals did not know that they were taking a placebo. But look at the outcomes among the compliers and among the non-compliers. It's almost the same as what we saw among compliers to non-compliers in the active treatment group, the clofazimine group. Why is there a difference? Why is there a benefit of compliance in this placebo group? It can't be due to the placebo. The fact that the compliers are taking this placebo pill, the pill itself has no benefit. It has to have something to do with the knowledge that you're taking a pill and that pill might be helping you, and therefore you might be changing your lifestyle, you might be doing other things into your lifestyle that's lowering your risk of death. That's the reason we need placebo pills. That's the reason we have to be able to compare active use versus non-active use. That's why we have to essentially blind people from knowledge of whether they're taking the active agent or not, and that's what the placebo pill is all about. Okay, that's what I wanted to say about post-randomization problems. Next time I want to talk about the role of a Data Safety Monitoring Board, a DSMB, and that will lead into the analyses we might do in these randomized trials. We'll talk about that then. See you next time.